Avoid inertia also, not in your speech, but how to avoid inertia in
Thank you, Arubda. I think my brief has been made rather simple. My brief is that I need to convince you there's nothing called stability in heart failure with reduced ejection fraction, and we should not have clinical inertia. So let us go. This is a quick way to diagnose heart failure. That is where we all start. This is a very good three-step diagnostic process. You need to have symptoms and signs. You need to have objective failure of cardiac dysfunction and supported by certain biochemical parameters. One thing you should not forget when you assess a heart failure is comorbidity status assessment. So this is very, very important for a clinician to do when he's facing with heart failure. Now, deliberately, this has been discussed by Dr. Pandey and later, that if you have a heart failure with reduced ejection fraction as you have in your initial presentation, and that fraction improves remarkably well, you do not reclassify it. Say, suppose the heart failure was 35% and you started therapy with it, and that improves to 50, not an uncommon entity. You do not actually reclassify that as mid-range or preserved ejection fraction. Why you say improved ejection fraction? Why do we put this as a separate entity? Because you should not discontinue the therapy which improved it. So do not reclassify after the initial classification. That is good. And I won't discuss the other entities. We will restrict ourselves to reduced ejection fraction. And as I said, and as Dr. Mohan put it, that it is worse than most cancers. So reduced ejection fraction mortality is worse than most cancers. Now, let us say, what about, so you have treated the patient rather well, the patient has improved, and he is now in what we call an NYNIHA class 2. Are you comfortable with that? He's on basically a therapy, maybe some of it not completely therapy, but are you comfortable with that? This is the reason I want to see you. This is a fairly sort of an important slide in my presentation. We are always worried about atherosclerotic vascular disease, and we interventional cardiologists have been somewhat seduced by interventions and atherosclerotic heart disease. So if you have a preserved ejection fraction, and even if you have 2 episodes of ACS, compared to the right side of the histogram, if you have just a stable heart failure with reduced ejection fraction, you start with a 10% event rate straight away, while someone with 2 MIs might actually be at 7%. So this is basically where we miss the greater evil. The greater evil is definitely a lower ejection fraction. So I'm trying to put this into the perspective why you should not actually be complacent and lulled into a comfortable situation. And why is that? Because even though you have treated them, even if you have initially treated them with the first presentation and the patient has become symptomatically better, you will still have a progressive deterioration, and with each hospitalization of this deterioration, they will never come back to the baseline where you started from. They will deteriorate. Ultimately, it's a downward spiral. So basically, clinical stability, ladies and gentlemen, is actually a myth in heart failure. There's nothing called stability in heart failure with preserved ejection fraction. And why does that occur? That occurs because basically, though your symptoms have been relieved, actually the pathophysiology unfortunately continues. The neurohumoral mechanisms actually are still progressive. So unless you're very conscious and assess these patients regularly and uptitrate their treatment, you will be at a loss. So this is what heart failure with NYHA classification. See the incidence in the 6 out of 10 NYHA classification in class 2 heart failure actually die within 27 months. This was the Paradigm heart failure trial. So even when you thought that they were stable, NYHA class 2, with reduced ejection fraction, and you did not actually look after their treatment aggressively, this will happen. You will have deaths. And this is the hard statistics which we have. So how can we reduce this mortality? By being much more much more aggressive, much more interactive. Now, this is basically a sort of a therapy of reduced ejection fraction over the ages. And if you see, there's a lull period between 2010 and 2014. Up to 2010, the beta blockers had come in, the ACE inhibitors had come in, the MRA had come in, and then there was a gap. Up to 2014, we only thought about neurohumoral inhibition and neurohormonal inhibition till we had a relatively new concept in 2014 that we need to do a neurohumoral modulation, where not all the compensatory components are actually detrimental to the heart. Actually, if you have the renin-angiotensin system, you need to actually downgrade that, but on the same time, you need to up-titrate the natriuretic peptide, which has got a vasodilator system, and that is what, with the concept of ARNI came in. And in 2014, that was the first, again, a change in the status of heart failure management, where an ACE inhibitor ARNI compared to an ACE inhibitor clearly showed a significant improvement. Mind you, the comparator arm, the placebo arm, was actually had the full treatment according to the then guidelines. So this is basically where there's a lot to be achieved, because you still have a significant heart failure mortality despite all the treatments. So what does the current therapy suggest? The current therapy, say, for example, in ACE inhibitor, you would actually consider an ARNI in nearly all patients with reduced ejection fraction, and whether in your initial presentation you would actually move on straight away to an ARNI rather than doing a trial with an ACE inhibitor in heart failure with reduced ejection fraction. I think we have now enough evidence and enough safety parameters to say we can do that to prevent utilization. So this is basically the success. So this is basically the NYHA2A 72% in the paradigm heart failure trial were NYHA class 2, and there was still a huge benefit. So changing them from an ACE inhibitor to an ARNI, even in stage 2 heart failure, in NYHA class 2 heart failure, actually improved outcomes. And let us see why that outcome improved. See the differentiation of the curve that occurs almost within 1 month of therapy initiation. So not only have you got to change it, you have to change it rather early and after your initial diagnosis. Similar story with an SGLT2 inhibitor. This is the DAPA heart failure trial with reduced ejection fraction. Again, the separation of the curve occurs within 1 month of therapy, and that is what a point I want to stress on. Not only there is a benefit, there is a benefit very early. So you need to initiate this therapy very, very early. What is the reason? What might be the reason? One of the reasons might be that the sudden cardiac death reduces actually in that first month. That is a postulation, and this was actually studied in the DAPA heart failure trial, but there was a composite decrease in ventricular arrhythmia. Again, the separation of the curve, if you look at absolutely on the left side, started very early. So treatment of this not only improves the hemodynamics, the heart failure component, recurrent hospitalization and mortality, it also decreases ventricular arrhythmias, which leads to sudden cardiac death. Is there a difference? Yes, there is a difference. If you do not use all these new therapies, the guideline-directed medical therapy, actually, if you have a suboptimal guideline-directed medical therapy, the outcomes are clearly not the same. So this is the differentiation between the two curves if you are not using it. So what is the actual scenario? Unfortunately, in India, 1 out of 4 only gets guideline-directed medical therapy. Even after diagnosis, even after such strong evidence, unfortunately, we are not doing too well. So why is that? This is basically, we can say, what is called the clinical inertia. And I think from the clinician, I think the best thing is my patient is doing fine. And I think that is one of the reasons. My patient is stable. So why bother do any bit more? Why change the ACE inhibitor to an ARNI if my patient is stable? On the other hand, on the patient side, he is a little reluctant. I'm doing so fine, doctor. Why do I need to change anything? I'm happy with the medicine. And of course, the systems. Unfortunately, it's not the insurance. The patient pays out of his pockets. And an ARNI therapy or an SGLT2 therapy will add on to his cost. So there's a inertia from the system itself. So this is basically why NYHA class 2 heart failure with reduced ejection fraction cannot be reduced as basically a low risk. And this is the definition of clinical inertia, is defined as lack of treatment in intensification in patients who are not on evidence-based medicine therapy. So even if the patients are stable, you need to strive to get them onto the most advanced form of therapy to reduce mortality. So use of ARNI is recommended as a replacement to ACE inhibitor in suitable patients, and as I have said, they can be actually used even as the first-line therapy without a trial of ACE inhibitors. So basically, this is the direct ARNI therapy, and I think this is an important slide. This is a comparison that on the top of the side, if you use all the 4 foundational therapies, ARNI, beta blocker, MRA, and SGLT2, they will certainly do better if you use an ACE inhibitor, ARB, beta blocker, and a digitalist. So if you see the ladder of the time, the more you use guideline-directed therapy, and the earlier you use, it is actually better for the patient. So what is the Indian, basically, what about these? Is there any proof of that? Yes, as I re-emphasized, this is a repetition of the slide. Class 2 heart failure NYHE2 was represented nearly 72% in the paradigm heart failure, and you still had a huge difference. And if you see this, the difference in the outcomes were even more prominent in the early heart failure in NYHA class 1 and 2 than 3 and 4. So that is the importance of using this therapy in still what we call stable heart failure. Don't be lulled into complacency. So basically, what about the Indian patients? We had some representation, not a lot, 266 Indian patients in class 2 in the paradigm heart failure trial. And again, they had a similar story. They did not differ from the overall outcome to benefit from that. So these were class 2 NYHA with reduced ejection fraction who benefited Indian patient from the early initiation of therapy. So this is basically, it follows the general pattern of therapy. We are no different. So time is essential. So this is the next part. Not only we need to institute this therapy, we need to institute this fairly early. And what I would say, this is from the 2022 recommendation for reduced ejection fraction. If you see the left side, the 4 pillars are there, are ARNI, beta blocker, MRA, SGLT2, and a diuretic as needed. Now, diuretic is something which you need to do, titrate according to the need of the patients. The 4 corners of the therapy. So how do we need to start them? If you see the proposed sequencing, this is called the rapid sequencing rather than the conventional sequencing. You need to get all of these 4 wonderful therapies within the first month of diagnosis because you are deferring in outcome in that first month. So the earlier you use it, the better for you. So this is how you do sequence it, beta blocker, SGLT2, ARNI, I think interchangeable. This is patient, I think the clinician to decide which sequencing should do better. But what you need to do is to introduce all of them and all of them rather early in your therapy. So in conclusion, the efficacy of each foundational drugs is independent of the other drugs. Very important. It does not mean that the benefit of an SGLT2 will negate the benefit of an ARNI. That does not happen. We've had some trials which showed a propensity matching sort of a trial and where the interaction was neutral, which means there was no interaction. And start a low dose in each class rather than try to push up each one of them to the maximum dose and then try the other one. So each class of drugs need to be started preferably at a low dose, and this should be a precedence over up titration of the artery. And start them early, mortality, because they affect mortality very rapidly within 4 weeks of initiating therapy. And in fact, some of these drugs can improve the tolerability of the other group of drugs. Thank you very much.
Thank you, Dr. Ghosh. The highlighting point has been hit heart failure early, hit it hard, hit it all thy might. Now, you can start all the 4 drugs together if the patient's profile permit. If it doesn't permit, at least start with 2 drugs, then quickly take over with the full dose of the other in 4 weeks. So this is open to discussion for 5 minutes for audience participation.
you are switching over from a patient on ARB to ARNI, you can do it in the same day. But if the patient is in ACEI and you want to change over to ARNI, you should at least give 36 hours. That is a recommendation.
Yeah, absolutely.
No, I think the message from the discussion we have so far for heart failure is clear that in this country, dominant heart failure continues to be heart failure with reduced ejection fraction. There is suboptimal treatment. The slide which you showed saying 1 out of 4 fails to get is wrong. It's 3 out of 4 fail to get guideline-directed medical therapy. We have data from Pinnacle Registry, where Praful Kerkar was the PI from India. We showed that the guideline-directed medical therapy was being used in 30% patients overall. So we have strong gaps. We need to fill up those. All 4 drugs need to be given. Whichever way you want, whichever combination you want to give, how quickly you want to, up to you. But eventually, as rapidly as possible, a patient on 4 drugs, patient would benefit. Having said that, we do realize that there are issues with regard to cost, number 2, compliance, and of course, our clinical inertia. We all actually talk in meetings about giving all these 4 drugs, but even cardiologists, 50% of the cardiologists wouldn't be prescribing all 4 drugs. And even 3 drugs will be prescribed not more than 60%, 70% of the. We do have issues and we need to improve our compliance. I don't know what we can say. When your patient is doing all right, the tendency not to increase the dose to the maximal tolerated dose is one of the things which we all are guilty of, and we should try to avoid that.
Okay. Thank you, Dr. Mohan and Dr. Debasis Ghosh. We are concluding the session.